Thrilled to have everyone here. Welcome to our March Let's Talk Menopause talk. Today we're joined by board certified dermatologist and Menopause Society certified practitioner, Dr. Corinne Erickson, to discuss skin and hair, a vital health sign hiding in plain sight. Before diving in and introducing our incredible speaker, I just wanted to have a couple of housekeeping and introductory items at the start. My name is Alessandra Henderson. I am the Senior Program Advisor to Let's Talk Menopause. Let's Talk Menopause is a national nonprofit changing the conversation on menopause to ensure women get the information they need and the health care they deserve in midlife and beyond. We host these monthly menopause talks to cover all of the topics that our community has come to us and wants answers from top experts in the space. They're central to our educational efforts. So if you like what you hear today, please go onto our website, letstalkmenopause.org, to explore I believe we're upwards of 40 plus talks across any number of deep dives with leading menopause voices. All menopause talks are intended for informational purposes only, not as a substitute for professional medical advice, diagnosis, or treatment. And a huge thanks to our sponsor, Bayer. Just a couple more housekeeping items. You may have noticed we've disabled the chat and the Q&A. If you do have a question or would like any clarifying point, please ask in the Slido app. It should be on the bottom or on the right of your Zoom. We will do our best to get through every question, but if we don't get to yours, we'll do our best to follow up. But please know, if you are asking a question, please try to make it a universal question or not a very specific medical question. It's hard for us to give one-on-one advice through these talks. There'll be a brief survey and a recording of the event at the end, so please stick around for that. Okay, now excited to dive into our talk and introduce Dr. Corinne Erickson. As I mentioned, she's a board-certified dermatologist and Menopause Society practitioner specializing in midlife skin and hormone health. Dr. Erickson is the owner of Georgia Skin Specialists and Clear Aesthetics MD, bridging dermatology, hormone physiology, and regenerative skin science. Her clinical focus includes perimenopausal skin changes, collagen loss, hair density decline, and inflammatory conditions in midlife. She integrates clinical dermatology and hormonal insight to position aging skin not as a cosmetic issue, but as a reflection of systemic health and longevity. We'll also share a link to her website and resources. She hosts an incredible podcast if you'd like to go deeper. So we're thrilled to share more of what more of her work. But I really wanted to start this conversation. So thank you for coming. I really wanted to start this conversation with you. We'll get into biology and treatment options, but I'm really fascinated by that last line in your bio where you position aging skin not as a cosmetic issue, but a reflection of systemic health and longevity. If you could start just by telling us more on your philosophy there.
Absolutely. First of all, thank you so much for having me. I've been really looking forward to this conversation because this is at the core of what I do every day with boots on the ground in clinical practice. And yes, I view skin as a vital sign. And the changes that are happening in our skin and hair are not these cosmetic imperfections that we've really been taught to believe that they are, but they are reflections of what's happening to our bodies internally. So, with the hair cycle being something that's constantly in rotation and the skin constantly turning itself over, these are areas that we can see on our body that often demonstrate internal physiologic shifts sooner than any of the other symptoms or manifestations that may come about. So, for example, while we're hitting perimenopause and menopause, and our bone density is starting to decrease by 2.5% per year, unless you have a non-traumatic fracture or you're lucky enough to get a DEXA scan before the age of 65, you're not necessarily going to see that change. But we're also losing 2% of our collagen per year and 30% within 5 years of menopause. Well, that's right on the surface. Those are changes that we can see. And instead of just looking at our face in the mirror and our hair and saying, gosh, I don't look good. What's wrong with me from an aesthetic standpoint? But shifting the narrative and saying something is changing. I'm noticing that my skin is drier. I'm noticing more lines. Maybe I'm starting to develop a little more loss of elasticity and sagging. If we can pause and before we start the cycle of being critical and going into fix it mode and say, wait a second, what could this be telling me? We could learn a lot about our bodies and our hormone status and what we may need to be addressing on a deeper level, even before some bigger problems arise. So that's what I mean by that. Skin is a vital sign. Our wrinkles are messages, and it's literally staring us in the mirror all day long.
That is very powerful as someone who is guilty as charged, right? And maybe some other people are nodding along of taking it and taking it just at that
Oh,
skin surface level.
same. It's a professional hazard for me. So
Um, I mean, you've mentioned, and it really is, right? Your body is telling you something. Um, in an earlier conversation or in preparation for this, you mentioned kind of intrinsic and extrinsic forces, genetics, time, hormones. If you could give just a little bit of some of the forces that are starting to create these changes, and then we'll go specifically into hormones.
absolutely. And this is what I like to call the vital skin framework. Because while skin is external, it's our largest organ and it's on the surface, the factors that are impacting it are not just external. So when we think about aging, you have extrinsic forces, and the sun is certainly a huge component of that. Environmental pollution that's creating stress is a component of that. What we eat, the way our sleep may not be optimized, those are things that we typically think we can have control over and are outside of us. But on the other side, we have the intrinsic forces of aging. And this is where I think we need to discard the comment, oh, you're just aging. You're just getting older. There's nothing you can do about that, because we know that there are. And within the intrinsic framework, yes, there are genetics. And can we change our genetics? Well, we can't change our genes, but we can change gene expression through the field of epigenetics. There's time, there's aging itself, which we really want as much of that as we can get. So we don't want to do anything to stop the clock to prevent intrinsic aging. And then there's our hormones. And hormones truly are, in women, a huge opportunity to address the way we are aging intrinsically and take back more control over that process.
Amazing. Well, maybe we can dive into hormones in a little bit more detail. So, um, what is happening to our hormones as we age and the
Right.
impact on skin and hair, right?
Absolutely. So the skin is actually an endocrine organ. It's an immune organ. The skin serves many, many purposes beyond just being the wall between the outside world and the inside of our bodies. It is hormonally active. I think it's important to understand that before we dive into the way the hormones are changing. You need to understand what they're doing. So, all hormones in the body interact with our cells through something called receptors. It's like the keyhole, and the key goes in, turns the lock, and opens up the range of activity. And in our skin, we have multiple types of cells. We have our collagen producing cells. We have our blood vessels. We have the cells responsible for producing what makes our skin hydrated. We have inflammatory cells. And what all of these cells have in common is that they all have estrogen receptors. They actually all have androgen receptors as well, but they are
What are androgen, just to clarify?
androgens. Yeah. So we think of estrogen, and then we progesterone, and then we think of androgens. And with androgens, we think more about testosterone and the adrenally produced
Mm.
hormones. So the main androgen that we're going to talk about is testosterone, although there are others. So our cells in our skin, all of them, even our pigment producing cells, are rich with hormone receptors. And what's happening is that when they bind with estrogen, estrogen promotes healthier blood flow to the skin. Estrogen promotes collagen formation, which gives our skin its structure. It promotes elastin formation, which gives our skin its stretch and recoil. It provides the driver for building hyaluronic acid, which is our water binding molecules in our skin. So estrogen is providing hydration to our skin. Estrogen is also mitigating inflammation in the skin. So while we are in our reproductive years and in an estrogen rich state, our cells are really bathed in estrogen activity, and our skin is functioning optimally with that estrogen exposure. So then what happens when we hit perimenopause? Well, then it truly becomes chaotic because some days our cells are bathing in estrogen and other times it's like an estrogen drought. And so that's when we start to get this mix of, am I dry? Am I oily? Am I inflamed? Is it okay? It wasn't okay last week, but everything feels out of balance this week. And I swear I'm seeing jowls that I didn't used to. What happened to my neck? So everything starts to show up. And sometimes in perimenopause, it feels like it's a mess one day and it's better the next. Because if you look at the hormone curves in perimenopause, that's what's happening. So then you hit menopause. Estrogen without external support goes pretty close to the floor and we get dry. We lose collagen, so we wrinkle. We lose elasticity, so we sag. We lose that inflammatory mitigation. So we're more prone to inflammatory irritant issues like rosacea and dermatitis. Our skin products are now no longer serving us. Dryness really does become a huge complaint that I hear. And all of this is also happening in the hair as well, which is rich in hormone receptors, which is why the androgen estrogen balance starts to shift in the way our hair behaves. So that's the biology. Estrogen is serving us. It's promoting the thickness, the stretch, the hydration, inflammation regulation. And when it drops, those things decline.
Yeah.
And we see change.
Yeah. Are there other, you mentioned androgens, and I know we've focused on estrogen, and that's probably where kind of a majority of, well, I'm just making assumptions here, but from a treatment perspective or addressing, but are there other factors that are contributing to this as we age, be it wrinkles, sagging, jowls?
Well,
Um,
sure. We do have those other extrinsic factors that are still at play, right? And that people will have different experiences with aging. You know, some people will age differently. You can look at your mother and your grandmother and you can kind of tell if you're going to be a wrinkler, a sinker, or a sagger when it comes to aging, just in general terms. If you've done a great job protecting your skin from the sun, then you may not have as accelerated of a course with this. And just as we have women who have totally normal levels of testosterone and androgen hormones, but their receptors are really sensitive to androgens and they get acne, we do have different degrees of sensitivity to estrogen in the skin. So not every woman is going to be the same. So estrogen and hormones are a huge part of the puzzle, but there are other key factors that are at play.
and I was going to ask how that might look different from, like you said, the reproductive age or window into perimenopause and menopause. Do you see kind of three distinct stages typically with that, or is it, yeah, what is the perimenopause versus menopause experience?
Perimenopause is like you're living all of the stages at once. You're going through
Reverse
puberty,
puberty,
you're
right?
going through like these crazy surges that might remind you of, of when you were pregnant. You're going through menopause like changes. I mean, you could be standing with one leg in a rainforest and one leg at a desert at the same time in
I raised
perimenopause.
my hand to that one. Yes. As
Yeah,
someone
it's
suffered from acne and accelerated wrinkles and dryness all at the same time, I get
it's
that.
yeah, it's the reality. And I know this in treating patients who are, very oily through here and acne prone through the jawline, which is a very androgen sensitive area. And then it's like we're treating dry, patchy dermatitis everywhere else. So you in perimenopause, you just got to be like ready for anything. Whatever phase is coming at
It's
you.
a little bit. Well, hopefully
Yeah.
not. No, this is we're going to get into offense.
Yeah, exactly. And then also just be kinder to yourself. And knowing that it's not that you're doing the wrong thing, it's just that your hormones are on this wild ride. But paying attention to the way your skin feels like it's on a wild ride could be the first insight that there's something going on internally that you actually do have agency over to address.
Yeah, yeah. And I really like and I was gonna lead with this at the top, but I know you think a lot too. To that point, there is the physical expression and then there's our emotional relationship throughout all these changes. And so
Yes.
the concept of feeling like yourself or, how you help women navigate this time and their relationship with themselves. Maybe if you could address that a bit.
Yeah. So I think that as women, feeling like ourselves is there's so much packed into that. It's all of the different roles that we play and our capacity to do those and keep everything afloat. It's our relationships. If we have children, it's our parenting abilities. With our careers, it's our professional engagement. And this is the time when we're really, thriving and rising in our work lives. So feeling like ourselves is more than just my back hurts or my shoulder feels stiff or I'm having hot flashes or I'm not sleeping well. All of that's important, but feeling like ourselves, I really think, is our ability to interface with our lives on a daily basis, both emotionally and physically. And a big part of women feeling like themselves is recognizing the woman that they're looking at in the mirror. And it can be very unsettling to look in the mirror and look tired. And we have known connections between facial expressions and facial features and emotional responses. And that doesn't make it a point of vanity. It is a opportunity to connect what we're seeing with our eyes and how we're feeling inside. And I think that feeling of looking in the mirror and feeling like things are falling, that descent, that, we're succumbing to gravity, the puffiness around the eyes, the hair thinning. These are things that strike pretty significant emotional blows to us as women and make us worried that the changes on the outside might mean that we're starting to fall apart, maybe not be able to perform as well and be as relevant. And it's important to acknowledge, to me as a dermatologist, I actually always lead with hair loss because I don't want women to think that it's a vanity point. I want them to feel like this is something I want you to talk about. Don't sit in your skin exam waiting and wondering how to bring it up. Let's just put it in the foreground.
Mm.
And I think that's a way that we can remove some of the emotional burden and stress around this.
I love that. Yeah, our relationship with how we feel about ourselves, right? And as things are changing is so
Yeah.
important to be able to talk about what might feel taboo or embarrassing. Uh,
Mm-hmm.
but also, it's interesting in working in this space, what I've oftentimes hear, especially women in their 40s, and it could be 30s, or, when as you're moving through the perimenopause transition, there's oftentimes this feeling of looking back, a lot of nostalgia for what you might have looked like in your 20s and 30s. And of course, that can carry through. But there's something about, and I'm not speaking entirely universally, but reaching 50, I think there's also how do we view all of this as a sign of living well for longevity and to come. And so,
Yes.
how we change our relationship with how we look and how we've shown up and the kind of a life well lived is critically important too. So we're not
I
trying.
agree. And the other thing I would add on to that is that when we hit our 40s and we hit our 50s, what I hear more and more of is, God, I should have. I should have done better with this. This is all my fault. And we need to stop that narrative because I do think that these messages of blaming ourselves and just focusing on the past and not finding an active way forward is what keeps women so trapped.
Yeah, 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 definitely. And I appreciate that. And it's amazing to see this menopause conversation happening. What might have been in very narrow spaces, maybe one friend or maybe your doctor, your family practitioner, your OB/GYN, if they were well versed in menopause
Mhm.
care. Now it's really spreading, and I really love what you are doing to bring this conversation in around how the midlife transition and hormones is kind of an aspect of your health just across the board, right? And skin and dermatology and just I really love how you are creating yet another safe space for women to talk about this and to find treatments and plan ahead for a long time health perspective. Uh, Getting back perhaps a little bit to some of the questions, because I'm sure we will get to
Yeah.
treat you and what you can do, because there are things
Sure.
you can do. And a big part of Let's Talk Menopause and also navigating this transition is that there are steps we can take. I'll get that to that in 1 minute. I did want to talk a little bit about anything before we go dive into treatments, because that'll be the back half of this. Can we talk about things that we can and should be paying attention to, especially in midlife? Be it, and there are two that we came up in our discussion, specifically skin cancer, as well as also vaginal health as well. Those are two big topics, but skin, we have skin all over our body, so not just limiting it to our face or hands.
Absolutely. And I think that there's some confusion in the world of skin health as to who owns the vagina. Well, I'll tell you, women own the vagina. We all need to take ownership of our vulvovaginal health. And hopefully, you have a dermatologist who is right there with you to support you. So, yes, skin cancer, we really start to see an uptick of that. Is it related to your hormonal shifts? Not so much as it is related to hugely to the extrinsic aging factors, especially with sun exposure over time. But things to pay attention to. And while it may be the reason, concern about skin cancer gets you in the door of the dermatologist, and I find that in my practice, I have more people seeking me out to do their skin exams, and then they find themselves talking about their vaginas and their sex lives, and everything can get better from that. But yes, you need to be having your skin checked because this is really the age when skin cancers start to manifest. Vaginal health matters, and don't assume that your OB/GYN is really looking at the area, and don't assume that your dermatologist is really looking at the area. You need to take ownership and advocacy for that area because things can go wrong. And you don't need to be embarrassed if it's itching or it's burning or sex is painful, because there are things that can be done about it. Rarely we even do see skin cancers. It wasn't too long ago that I did diagnose a vulvar melanoma on a woman in her 40s. So this area needs to be checked. You need to look at it. If you don't have a mirror and if you haven't gotten up close and personal with your labia, I encourage you to do it because I think it's important to understand the anatomy and check in with it. And then see if you are noticing any changes over time that you could see visibly that might be connecting with some of the symptoms you're having. But yes, you need to be checked. You need to feel comfortable talking with your dermatologist or your gynecologist, whoever you're partnering with in that care, and hopefully it's both, to discuss the health of that area because it's another area where there are things that we can do, both preventatively and correctively. And I'm talking about vaginal estradiol, and I know we'll get into, discussing the magic of that topical treatment. But just being really mindful of it so you don't end up in diapers or with UTIs. And the skin is at play with this.
Yeah, I have a personal mantra, which is no diapers. And if that happens, so be it. But there are things we can do, right? And so appreciate.
Absolutely.
Yeah. Well, maybe we can get into, yeah, let's talk about treatments. So a reminder at the top of this, and you'll probably double down on this as well, but you do not need to spend a ton of money here. I'm sure there are always options across the board. But maybe let's start with skin.
Mhm.
Can women do to take care of our skin?
So, exactly. You don't need a regimen that costs hundreds of dollars a month, and you don't need to engage in a lot of high priced treatments. What do you need? Every woman needs an SPF on her face every day. I mean, every human does, but we're talking about menopause. So, we're talking about women to be just clear. So SPF every day, because that is an extrinsic aging impact that you can control. But beyond that, that sun exposure is injuring your skin barrier. And one of our core goals in perimenopause and menopause is to support the skin barrier. So what is the skin barrier? It's the wall, yes, between the outside world and the inside world, but it's also an interface and a very active organ that's helping control our inflammation. It's helping control hydration levels. So we need to keep it intact and nourished, and sun protection is a key way of doing that. Beyond that, you need a good moisturizer. The water content of the skin does start to decline. We talked about the biology behind that. So a moisturizer that's going to infuse the skin with hyaluronic acid, and there are many available inexpensively over the counter, and that has topicals that contains lipids and cholesterol, and there are many available over the counter. You don't need to spend a fortune on this to help seal that hydration in. So you think watering and sealing.
Once a day or twice a day or how?
Sunscreen in the morning. And if your skin is dry, I recommend doing a layer of a moisturizer and then sunscreen in the morning. And then at night, that's really when you need to focus on sealing moisture in, because our skin cells have a circadian rhythm, just like our brains do. And our skin cells are programmed to really protect during the day and then to repair themselves at night. And
Wow.
so this is at night is when we want to focus on more of a reparative regimen, but it's also when skin cells naturally open up more to let out more water. So you want to block that. We need to help ourselves out and seal it in. So morning, I like to think about protecting with topical antioxidants like vitamin C, additional moisturizer if you're dry, and SPF. At night, you need to be applying, if you can tolerate, retinols. You don't even need a prescription retin-A. A retinol in an over-the-counter formulation is great. Retinol, retinal, and then moisturizer. And then those retinols can repair, crank up your DNA repair enzymes, give them the support. They already want to work overnight, so help them do that. And then seal in the hydration so that you wake up in the morning and you don't feel like your skin is tight and itchy and irritated.
There was a question about itchiness, which a couple and dry skin, which I'm going to get to, but while we're the lastly around call it eye creams or patches or whatever. This is a menopause
Oh yeah, like the gel patches.
gel patches and eye creams. How much do you recommend we start adopting all of that regimen?
So I think the patches are fun. I like to use them sometimes. I don't think they really do a lot more than a good eye product. And the eye products, again, do you need a special eye product? The only thing you need to be careful of with the eye area is that if you put something that's too occlusive on it, like if you're slathering Vaseline or Aquaphor or a thick body cream on your eye area, as you age and your skin cell turnover is slowing down, that's when you can get milia. And if you've ever had them, you know what I'm talking about, but they're the hard white little bumps. They can happen anywhere, but they love to happen around the eyes. And it's usually because women are noticing their skin's getting drier, their eye area is irritated, they're putting way too heavy cream on the area, and then those oil glands are getting occluded and they're getting tiny little cysts
Okay.
building up. So this is where choosing an eye product can be really helpful. And yes, the eye skin is thinner, so you're going to see the age-related loss of collagen faster because there's less to lose, and it's more sensitive and drier. So I do think that an eye product becomes worth it when you're in your 40s and 50s
Okay.
and beyond.
There was actually a question around eye dryness, and whether estradiol can actually increase eye dryness. Is that
So I haven't seen the data on that. And I am not an ophthalmologist. So the area in
Oh, I was going to say,
oh
but
yeah.
while we're talking about eyes, maybe we can throw that.
Yeah, so I again I would defer to my ophthalmology colleagues on dry eye, but I do know from personal experience and conversations that what can happen is our secretions in our eye area do change as we age, and they become more viscous and thicker and not as loose and lubricating of the eye, which makes us more prone to dry eyes. Also, as our skin barrier becomes a higher pH with the loss of estradiol, we can end up with more inflammatory microbiota, like little bacteria and demodex around the eye, and we can end up with ocular rosacea. So, tending to the eyes does become very important, and using drops that can moisturize the eyes, using some gentle heat strategies to keep the secretions from the glands moving so you don't end up with dyes, which are more common in perimenopause and menopause, can be really helpful.
Interesting. Um, while we're talking about dryness, their question was, if you're not on HRT or if this poster is not on HRT, is it normal to have dry eyes, dry skin, dry scalp, dry mouth, dry everything? She is post-menopause now.
So postmenopause, yeah, again, it starts to feel like the desert
Yeah.
because if you're not replenishing your estrogen, then you're losing that hydration component. Now, does it mean that you're going to be dry forever if you don't go on estrogen? No, it just means that you're going to have to replenish it in other ways. And that's both internal hydration, but also external moisturizer. And remember, the body, the skin is not just your face. We often forget that that's actually not the majority of it. So using moisturizers after you shower, not using harsh soaps that strip away hydration from your body skin is very helpful. Focusing on the areas that just, I call it the pits and privates approach to washing yourself. You soap those areas up every day and leave the rest of it alone and just focus on really nourishing and hydrating.
And what about itchy skin? Itchy either, like you said, on your arms or legs or elsewhere, but also itchy down there.
So itching is usually, if you've ever been told that by the time your mouth gets dry and you're thirsty, you're already dehydrated. By the time your skin gets itchy, that's your skin like screaming at you that you are dehydrated. And the itch is not just dry skin. The itch is inflammation, whether it's on your arms or your labia. There's inflammation at play. So what happens as we lose our estrogen content over time is that the pH of our skin and the pH in our vulvovaginal area shifts and it actually becomes higher. And with a higher pH level, there are bacteria that are more problematic bacteria that then overgrow. So we see more Staphylococcus aureus, staph, on the skin. We see more Candida albicans in the vulvovaginal area. So the estrogen drops,
What are
the
those?
pH, the pH goes up. We have more bacteria and problematic yeast that are then shifting in their proportions on our skin and in our vaginal area. And then inflammation and itching can ensue. And it may not even be a full-blown infection. It doesn't have to be a full-blown infection. We know that not everything that makes the vagina itch is a yeast infection. If you've been misdiagnosed with a yeast infection a few times, as many women have, you know this, and it's frustrating.
Got it.
Yeah.
What I heard is that it could, like you said, it's that skin that's screaming at you. It's already, incredibly dry and either needs.
And once you hit that itchy point, oftentimes it's hard to just moisturize yourself back into it. And there's this misconception that my skin is dry, so I need to just drink more water. It actually doesn't work that way. Yes, you need to drink your water, but you also have to apply hydration directly to the skin. It's right there. It's in front of you. It's accessible. It's not like trying to moisturize your small intestine. Just put some moisturizer on.
If someone is taking an estrogen blocker, will all of these treatments work the same?
So being on an estrogen blocker, and I have many, many women who are on estrogen blockers as part of their breast cancer treatment, it does generally create even more of a challenge with dryness. And so we have to do more. It doesn't mean that it's a lost battle at all. We can oftentimes we'll switch to a moisturizer combination that has more occlusives in it, things that really protect the loss of hydration.
Like Vaseline
Um,
or Aquaphor, that
yeah, like a Vaseline or an Aquaphor. And if we're talking about on the face and those feel too heavy and too thick, there are some really nice options like Cicaplast and Ciclefate that are available over the counter that women can reach for. So it just means that we may have to do a little bit more, but we can do a little bit more in those cases.
wonderful. There were some questions while we're on the topic, and we will get to hair after this or as we move through skin. But
Mhm.
um, there was question around the milia and
Sure.
how do you deeply moisturize if you do have them, and or how do you get rid of them, and then how should you be moisturizing?
Okay. Well, let's talk with how to moisturize. So go with a lighter gel-like moisturizer in the eye area and truly the ones that are formulated for the eye area that are not really thick and heavy are going to be suitable choices. You can even find some that have a little bit of low potency retinol in them to help promote skin cell turnover as well. So it's really just avoiding the thick ointments unless you need to do that to treat another problem. Once the milia show up, what do? Well, you don't try and pop them like a pimple because they're not pimples. They actually have a full covering of skin on top. And in order to get rid of them, we have to gently lance them with a tiny sterile needle and then use cotton tip applicators, AKA Q-tips, to pop them out. And it can be a little bit of a challenge. Now, the good news is that a lot of them will go away on their own. And we can incorporate if you don't have access to somebody to take care of those for you, if you don't want to go to the expense, because oftentimes that is considered a cosmetic removal, you can incorporate a mild alpha hydroxy acid cleanser in your regimen to help just unearth some of that buildup of skin cells. So something with a little glycolic or a little bit of lactic acid. Um, Cetaphil makes a great one, makes a very gentle exfoliating cleanser that's affordable, that's great to use, that you could gently incorporate a few times a week to help reduce that. And it may free some of those up slowly over time, but don't try and pop them and don't stick a needle in them yourself, please.
Good recommendations. Uh, you mentioned Cetaphil. I'm a big Cetaphil and CeraVe fan here. Is
Yeah.
there, I know you are, we're going to get asked this, and at the top of this, Let's Talk Menopause does not endorse any particular products or brands, but is there an eye cream or moisturizer brand that you tend to recommend?
So on the medical grade side, and I do some speaking for this company, and we carry it in our practice. So I just want to be very transparent with that. But I carry what I use. So there you go. I use a lot of Hydrinity because it's hyaluronic acid. It's not heavy. It's not too occlusive, um, and that's going to be at the medical grade end of the skincare spectrum. And then over the counter, I like CeraVe and Cetaphil. I like La Roche-Posay. Like generally, I think that these lines do a great job of incorporating science at a more accessible price point. And
I'm sure you're going to ask that. That's kind of like, how do
yeah,
when we're actioning on this, because there's always these terms that we've all read, I feel like in magazines since we were, young girls of hyaluronic acid and, call
yeah. And hyaluronic acid, it's a water binder.
mm.
It binds 1,000 times its weight in water, and we're losing it as our estrogen drops. So we're just trying to infuse more of that into the skin.
Well, let's talk about topical estrogen. That's kind of
Yeah.
hit the menopause converse or the conversation like a wave, a tsunami this in the last couple of years. So, what are your
Yeah.
thoughts on topical estrogen?
Well, first, I want to establish that there is data in this space. There are studies on topical estrogen. Yes, a lot of them kind of came to a screeching halt mysteriously around 2002, but there is data around topical estrogen, and there are multiple studies. And I have a nice reference list in my podcast if anybody's interested that's totally free. Um, but there's studies that show the benefits of topical estrogen to facial skin. And I just think it's important to say that because there's a lot of naysayers who are saying there's no evidence behind it at all, but that is not true. In fact, there's a ton of data for estradiol in the skin. It's the vulvovaginal skin. And what we know is that what the skin, whether it's on our face or it's in our vaginal area, is very rich with estrogen receptors. We know what that estrogen is doing biologically. And we know that by putting vaginal estradiol in the vulvovaginal area, we improve hydration, we improve skin thickness, we improve the skin pH, we improve blood flow, we reduce the rate of UTIs. So we have this vast amount of data and science supporting vaginal estradiol use in that area. We also have the safety data behind it. You can apply the same scientific foundational principles to putting it on the face where we also have estrogen receptors. And we know from clinical data that loss of estrogen is creating estrogen deficient skin. And there's a whole body of literature around estrogen deficient skin. And guess what it is? It's dry, it's thinning, the pH is changing, it's more inflamed, and it's more susceptible to infections. So, studies have shown that putting topical estradiol at the local therapeutic dosage, which is 0.01% vaginal estradiol, or estriol formulations, which is it's a weaker estrogen with a higher affinity for estrogen receptor beta. Putting those on the skin have shown improvements in hydration, in skin thickness, that's the collagen stimulation piece of it, and reduction in wrinkles. So we have the science, we understand the biology, we understand the science, and we have the data that supports it.
Yeah. Um, how often and when can or should, I know there's really no should here, but when should a woman start to consider this?
Well, vaginal estradiol, I think, should be sent to every woman as a 40th birthday present, maybe 38, as it seems to happen. I mean, I hand this out. I hand out prescriptions for vaginal estradiol all day long because it literally can't hurt anything for a
So
woman.
at 40, right? And again, we all know that we're all on
Yeah.
different
We're
timelines.
all on different time frames. I say 40 because we like to anchor in things, right? Like that's just the way it works. There's a threshold for everything. But for some, it might be 35. For some women, you might not have any symptoms or evidence of perimenopause until 45. I mean, there's a range, but on average, I would say a 40th birthday present for every woman should be a tube of vaginal estradiol cream because there's no reason to wait. We
Okay.
know it's safe, we know it's effective, and you want to get ahead of that problem. You don't want to find yourself at 43 chasing after recurrent UTIs. And dang it, we could have started doing something about this sooner.
And how about thinking about it as a face cream?
So, as a face cream, first of all, important consideration if you have melasma, which is a hyperpigmentation condition of the face that is sensitive to this combination of sun exposure, heat, and hormones, mostly estrogen, but also progesterone, topical estradiol on a sun exposed area could absolutely exacerbate it. And I do not recommend doing that. There are other treatments that we can pursue, as we discussed.
Mhm.
The studies that look at topical estradiol for the face have looked at it on a daily treatment basis, so applying it every day. I find vaginal estradiol a little thick for every day, and I use more of a protocol that mirrors the twice a week from the vulvovaginal literature. And I do recommend applying it personally at bedtime over morning, although this is where we get into very gray area guidelines, right? Number one, this is totally off label to use vaginal estradiol on your face. It does not have FDA approval. In dermatology, we live in an off label world a lot. And I think we have to increasingly get comfortable in an off label space because waiting for these huge randomized controlled trials to happen is not benign. Women need help now. We don't have time for decades more of research to get women feeling better. I feel really strongly about that. So I recommend nighttime because of its interaction with your pigment producing cells and potential exacerbation of sun sensitivity. And then I recommend anywhere from twice a week for vaginal estradiol preparations to every night for the slightly less potent estriol preparations.
Okay. There are a couple of questions asking if estrogen cream can be found over the counter, either topical for your face or vaginal. Uh,
No, estrogen creams are currently not over the counter. I certainly hope that they will become over the counter, but at present, no.
it's that
Um,
gift basket that we can send through the mail for friends.
exactly, exactly. So no, you do need a prescription for topical estradiol. And I get this question a lot. You need a prescription for topical estriol as well.
Okay. And what happens if you start after menopause, or even someone asks 15 years after menopause with some of these products? And
Better
specifically,
late, better late than never. You'll still get benefit from
great,
it.
great. Um, there are fast and furious questions coming in, and I also want to make sure we get to hair, but very quickly, if we can, what about sagging and dark areas under the eyes?
Okay, so sagging. Here's the story on sagging. There is not a cream, including putting topical vaginal estrogen on your face, that's going to fix jowls. Jowls are a complicated, and that's usually what people mean by sagging, right? It's the falling down and forward of the skin that becomes problematic. Sorry, my watch just demiked me. Yeah, so you can't treat jowls topically. You have to address the physical forces that are at play, which is loss of volume here, which, by the way, bone density loss in menopause. We're losing bone density in our face as well as in other areas. We're losing elasticity, so it's sagging. So we have to restore volume and integrity here. And then also there's a force pulling down that creates the sagging. So fixing the jowls becomes more of a treatment. You need truly more of a procedure to
Got it.
address that.
Okay.
That's just the bottom line. If a cream tells you that putting it on is going to solve your jowls, if you think that wearing, I call it a jawline pantyhose contraption, is going to lift your jaw up, I just don't spend a lot of money on it because it's going to be very disappointing for you.
Right.
Now, under discoloration in the under eye area, again, it's multifactorial and it worsens because of puffiness, thin skin, congestion of our blood vessels in that area, and pigment accumulation. So, this is where just a good hydrating skincare product made for the eye area can really be helpful. It's where some cooling patches may be helpful. It's where learning to do a little lymphatic drainage yourself could be helpful. But there's some work that goes into that.
Great. Maybe we can, because I keep hinting at this. Let's talk a little bit about hair loss.
Sure.
We can. So, what is going on? And then what can we do about it? Big question, but
So women, if you think you're thinning, your hair is thinning, it's not in your head, it's on your head, number one. And it's not something to keep to yourself or worry about silently, because the sooner we intervene, there's more that we can do. So, what's happening with it? A big part, female pattern hair loss is more than one thing. Okay. Male pattern hair loss, a lot of it is just sensitivity to testosterone, but females, it's more complex. So, it's a complex interplay of our hormones where, as our estrogen drops, our testosterone is getting louder. It's gradually dropping too. We know this, but estrogen drops really fast. And it's that relative shift that, if you're genetically predisposed, can cause your hair shaft to become thinner and then eventually less dense. So hormones are playing a role. Also, estrogen is important in maintaining the healthy growth phase of the hair. We call it the anagen phase. So as we get older, our healthy growth phase gets shorter and our hair then gets thinner, and we aren't able to grow it as long as we may have in the past. Then we have other things going on. Our bodies are more inflamed. We are generally vitamin D insufficient, which can impact the hair. Ferritin deficiency is a big problem, especially in perimenopausal women, when even if your period's every 8 weeks, it could look like something out of The Shining. So it's really important to know that the hormones are at play in different ways, and those can be addressed. There's also the stress component that can create chronic telogen effluvium, which, as we're sandwiching between aging parents and kids going through puberty, that can raise our stress levels up, whatever that life circumstance is, and shorten the anagen phase. And then you also have these, these nutritional issues and insufficiencies that we may need to address. So it's a long conversation. It's not a doorknob drop at the dermatologist. It's not a, hey, by the way, my hair's also thinning. Like, this deserves time and attention from a dermatologist who loves to take care of hair loss, because it is hard and it's going to take time, but
Is
it's
there,
doable.
what does that process look like? Is there testing? Do you always start with whether it's a product or a prescription? If you could just walk a little through
Sure. The most important test is,
if they come into a dermatologist, they have
yeah.
concerns.
So more important than any blood work or biopsy is just sitting down and listening, because the woman often tells you everything that you need to know to help. Okay. What's going on in her life, what's going on with other symptoms around menopause and perimenopause, on and off medications, stress levels, sleep, dietary changes or shifts. Have you been on a GLP-1 and you've lost 30 pounds in a relatively short period of time? So most of the information just comes from that conversation. Beyond that, there are some labs that I think are very helpful, because there are some more silent, insidious things that are actionable that we need to find. We need to check a ferritin level, not just an iron panel, but a ferritin level. How much is left for your hair after the red blood cells get what they need? We need to check on vitamin D. I mean, as a huge purveyor of sunscreen, like, we are creating some vitamin D deficiency and insufficiency, and we need those levels, I think, truly higher than the recommended levels. I like to get people between 40 and 60. I like to get a ferritin over 50, if not over 70. I check a full thyroid panel, not just the TSH reflex T4, but let's take a deeper dive into what each of those thyroid hormones are doing, because we know that thyroid disease, hypo and hyper, is more common in perimenopause. It's much more common in women, and it causes hair loss. And then beyond that, do we need a biopsy? That's really when we get a little bit more in the weeds with specific concerns, but there are other tests that can be done if need be.
That's great. And you mentioned and you hinted at, call it vitamin D or, various level iron. There was a question earlier, and we do know that diet can greatly and
Yeah.
express itself in our skin and in our hair. Are there supplements or collagen? There was a question around collagen. Like, are there things that women can start to consider as we hit perimenopause and menopause transition?
Yeah. I have an integrative background in dermatology as well. And so I really believe that the best source of nutrition is from your diet. So plant forward, a reasonable amount of protein, and then looking at what you're getting and supplementing smartly with what makes sense. And it is more difficult to get adequate vitamin D from the diet. Almost everyone needs a supplement for their vitamin D, and that dosing may range from 1,000 IUs a day to prescription doses that are significantly higher. More and more women have gone plant-based or more plant-forward, and with that, there could be need for iron supplementation. There are many hair supplements out on the market, and what is important to know is that there is no data that biotin supports hair growth. It will not help your hair loss. Biotin deficiency is rare, but all of the supplements tend to include it because of that association. But you don't need to be just imbibing high quantities of biotin. If you want to invest in a proprietary blend, like a supplement, there are several brands that are reputable and have clinical data behind them, then I would make sure they're third-party tested and they have clinical data backing up their claims.
Gosh, now you've piqued my curiosity. Is there something to even look into on that front?
Yeah, there's a lot to look into, but I consider supplements for hair loss really an adjuvant treatment. If a woman is truly having hair loss, you're not going to fix it with supplements alone. Again, it's not just one thing. The supplements may be a part of the puzzle, but there could also be a sleep debt that and sleep habits that need to be addressed. There could certainly also be some hormone shifts that need to be addressed. We can support the anagen cycle. So before you spend a fortune on hair supplements, I would have a deep dive conversation with a dermatologist about what's at play and what is going to be the most impactful for you.
Do you see other, and there's a question around, do you see other benefits or negatives of taking these? I know you're looking at it through the lens of efficacy for hair growth, but is
No,
there,
the advantage of taking the supplements that have clinical data behind them that are not just hefty doses of biotin is that they're really not going to do any harm. They're often they have anti-inflammatory components, they have some vitamin D, they have zinc, they have B vitamins. Some even have some stress adaptogens that might help regulate cortisol a little bit, some saw palmetto to help regulate DHT. So most of them are not going to hurt anything. But the problem is these hefty high dose biotin supplements can screw up your thyroid test results, which a lot of women in midlife are getting their thyroids tested because the symptoms are basically the same as the symptoms of being a midlife woman, which is fatigue, dry skin, hair loss, trouble with weight. So you don't want to screw up those test results. And they can actually mask cardiac enzyme elevations. And this is a huge problem I have because heart disease is the number one killer of women. And we present differently with a heart attack. So I don't want to show up at the ER with, a heart attack. And because I've been taking 10,000 micrograms of biotin, it gets missed. That makes me nervous. I don't think those are benign.
we're edging into the last couple minutes here, so I'm going to ask a quick question here. There was around hair growth, unwanted hair growth, chin, nose,
Yes.
etc. What can we do?
Welcome back to the androgen balance, right? So women get hair growth when women get hair growth where men typically get hair growth and women don't, we call it hirsutism. And that is androgen driven hair growth or testosterone driven hair growth. And most of that hair growth is coarse and dark. So this again, like, are your hormones optimized? Are you in perimenopause? Do you need more estrogen? There is a role for blocking androgens carefully and thoughtfully in perimenopause and menopause to reduce some of that hair growth. But sometimes that comes at a cost because we also know that women need testosterone. So we want to make sure we're having that conversation. But generally, physical methods of hair removal can be helpful as well. So yes, there are options, but again, it's a nuanced conversation.
Yeah. Well, we are just about, and we are, I think, yeah, last month we had a talk on testosterone. So if you are interested in going in a deep dive around testosterone, not just in the impact on skin or, hair growth, but to go broader, because that conversation is coming up, please check out our website. We're gonna wrap up in about 1 minute, but are there, always like to end with what is your kind of if anything we missed or a final call to action for anyone listening on how they can approach their skin and hair as a vital sign?
I would say there's three things. One is protect what you have, whether you're 35 or 65. Protect your skin. Use your sunscreen. If you're dry, listen to that. It's telling you your skin's dehydrated. If your mouth's dry, you need to drink water. If your skin's dry, you need to hydrate it, maybe differently than you used to. Manage inflammation. Just stop accelerating the loss. It's not a foregone conclusion. Number two, replace what you're losing. We're losing collagen. We're losing hydration. We're losing estrogen. If replacing that is appropriate for you, replace what you're losing because perimenopause and menopause can be a deficiency state, but we can optimize that. And we do have the science, the technology, and the ability to bring it back. And then finally, treat your skin like a vital sign. Don't treat it as a demonstration of your flaws, your shortcomings, of things you should have done, would have done, could have done years ago. Look at your face as a message of what the inside of your body is telling you. and listen to it because it really, you'll look better and you'll feel better if we can tie all of that together. Your skin is not a problem, your skin is a clue.
Like very, very powerful words to end on. Thank you so much, Dr. Erickson. So informative, so empowering, very, very thoughtful in how we can reframe this conversation. So thank you so much for joining us today.
You're welcome.